Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. In this case, we have a 16-year-old African American female who comes to the clinic for right leg swelling. Patient has had swelling of her right leg for the past 6 months. Swelling is mainly in the foot, ankle, and calf. The swelling does not improve with elevation of the limb and does not get worse with standing. She denies any pain in the right leg. She does not remember any trauma or injury to that extremity. Her left leg appears fine. She denies any respiratory symptoms or shortness of breath. No vomiting, no diarrhea, no urinary changes, no rash, no eye swelling, no allergic reactions. She has been feeling more tired than usual for the last 2 months. Past medical history, she had post-streptococcal glomerulonephritis at 9 years of age. She has had bad menstrual cramps and has been on oral contraceptive pills for the past 2 years. Travel history, she went to the Dominican Republic for a school trip about 3 months ago. There are no known drug allergies. Immunizations are up to date, and she received the Gardasil or HPV series and Menactra, the meningococcal vaccine, last year. Social history, she lives at home with her parents and a 12-year-old brother. Family history, mom recently was diagnosed with breast cancer and had mastectomy last month. Father has liver cirrhosis from alcohol. On physical exam, her temperature is 37.7. She has a heart rate of 82, a respiratory rate of 20, a blood pressure of 128/72. Her height is at the 50th percentile. Her weight is greater than the 95th percentile. Her BMI is 31, which is greater than the 95th percentile. In general, she is alert, awake, and cooperative with no distress. HENT is normal. Neck exam, she does have a few 1 centimeter cervical lymph nodes bilaterally, but no thyromegaly. Lungs are clear. Cardiac is normal, with the exception of a grade 2 out of 6 systolic ejection murmur at the left lower sternal border. Abdomen is benign, although she is obese. Extremities, no clubbing or cyanosis, and a negative Hohmann sign. The right leg has some non-pitting edema, mainly of the foot, ankle, and calf. And when you measure the circumference, the right calf, the right ankle, and the right foot are a little bit larger compared to the left side. Neuro exam, there are no focal deficits, normal reflexes, and the gait is normal. Skin exam, there are no lesions, no rashes, and no skin breakdown. To summarize our problem list, we have a 16-year-old female coming in with right leg swelling and edema for the last 6 months. She has been fatigued for the past 2 months. She traveled to the Dominican Republic about 3 months ago. She has a history of PSGN at 9 years of age. She is taking oral contraceptive pills for the past 2 years. There is a family history of breast cancer and liver cirrhosis, and she has a systolic ejection murmur at the left lower sternal border. So in this case, we have a 16-year-old female coming in with right leg swelling or lower extremity edema that's been getting worse over the last 6 months. So let's go through the differential diagnosis of edema, lower extremity edema, and what are the causes of that, and try to understand what might be happening with this particular patient. So when you think about edema and lower extremity edema, you can break it up into kind of things that will cause bilateral lower extremity edema and things that will cause unilateral lower extremity edema. So let's talk about some of the bilateral causes. One of the first organ systems you have to think about when you have bilateral leg swelling is going to be renal causes. So when you think about renal causes, we can just divide it up just simply right now as nephrotic syndrome, or nephritic syndrome causes, right? So either nephrotic or nephritic type of causes of, of edema. I'm not going to go into the pathophysiology of each one of those and how how they differ. So you can look that up and read more about it and the different causes of nephrotic syndrome or nephritis and nephritic type of processes. But suffice it here to say, renal causes are a big consideration when you have lower leg edema and bilateral lower extremity swelling. So this causes bilateral. Other causes would be cardiac. So again, when you have bilateral causes of lower extremity swelling, in addition to renal causes, you think about cardiac. So you think about CHF, so heart failure, can give you bilateral swelling and edema of the lower extremities. You can have a pericardial effusion that can also cause poor cardiac output, and that can give you bilateral lower extremity swelling and edema, or something like pericarditis could do it as well. Again, giving you poor cardiac output, and therefore lower extremity swelling bilaterally. In addition to cardiac, so after renal, cardiac, and then we think about liver causes. Liver failure and liver issues can give you bilateral lower extremity swelling and edema. So if you have liver failure for various reasons, whatever reason might be causing that, if you have like hepatitis or cirrhosis or anything like that, that can cause you to have bilateral lower extremity swelling and edema as well. Then, there is a family history in our patient of the patient's dad having cirrhosis, so something to keep in mind and consider as well for our patient. After liver, I think the next one that you think about is going to be GI causes. Other GI separate from the liver would be if you have like low protein, and that could be liver related as well, right? If you have a low albumin, low protein level, that can cause you to have the bilateral lower extremity edema and swelling. But if you have like severe malnutrition and protein deficiency, that can cause you to have the edema, or if you have like diarrhea and you have a protein losing enteropathy, anything that causes you to have loss of protein in your GI tract and your stool can do that as well. So any type of inflammation, things like IBD, celiac disease, things like that can cause you to have a loss of protein in your stool, and then you can have bilateral lower extremity edema. Another category to think about would be endocrine, causing you to have bilateral lower extremity swelling or edema. So you might think about like mixed edema or hypothyroidism, right? So mixed edema or hypothyroidism, giving you the bilateral swelling of the legs. So that's a consideration as well. And then if you have electrolyte imbalance or you have sodium retention for some reason, that can give you bilateral edema of the lower extremities as well then. So all of these causes on this side right here, so these are all causes of bilateral type of lower extremity edema or lower extremity swelling, right? So all of these would be causes of bilateral lower extremity edema and swelling, okay? And in our patient, we have unilateral, right? Just the right leg is swollen. So now let's talk about what are some causes of unilateral lower extremity swelling, unilateral edema. So let's talk about that then. So these are all bilateral, and now let's talk about and focus on some of the unilateral causes as well. So the first category, the big one, is going to be vascular causes, right? Which is a huge consideration in our patient and in any patient, especially coming in with unilateral lower extremity edema and swelling. You have to think about vascular causes. So she could have some sort of blood clot, right? Or she could have like a DVT. She is on OCPs for the last couple of years. So she's at risk for a DVT, so that definitely is something to consider. Or also if you have a sedentary lifestyle and you're obese and you're not as active, that can set you up for blood clots and DVTs as well. Or if you have some sort of like chronic venous insufficiency, that can give you the clots and or more like the swelling than So venous, let's see, this is an N, venous insufficiency for various reasons. Can give you swelling of the lower extremity as well. And then if you have the blood clots related to some sort of hypercoagulable state, right? So if she has some hypercoagulable state, right? That sets you up for blood clots as well, right? So she could have some sort of like factor V Leiden deficiency, right? So factor V Leiden, right? That's a cause of hypercoagulability, right? She could have MTHFR issues, MTHFR, and that can cause you to have hypercoagulability as well, or you can have a protein C or protein S deficiency. That can lead to hypercoagulable states as well. Or if she has sickle cell disease and has vaso-occlusive crisis and occlusion related to that, that can cause you to have unilateral edema as well then, under vascular causes, okay? So again, under unilateral causes of lower extremity swelling and edema, a big consideration is some sort of vascular issue, and you have to think about that urgently on these type of patients. And additionally, she could have some sort of tumor that's actually causing some sort of compression, extrinsic compression on the vascular system, causing venous stasis or edema as a result of some sort of lymphoma or some sort of mass or something pushing on the vasculature, causing to have the unilateral swelling as well. So these are some things you have to think about: unilateral causes of and vascular causes as well. When a patient presents with unilateral lower leg swelling or edema. In addition to vascular causes of unilateral edema, you also have to think about some sort of localized type of process of that lower extremity, right? So something localized causing you to have the edema. So you can just have something like a cellulitis in that area, and you can have a lot of edema and swelling locally in that area. In addition to that, you might have some sort of allergic reaction or insect bite, something like that. So a local like insect bite or type of an allergic reaction causing you to have localized edema or swelling, or some local trauma or a fracture, you know, something localized that's giving you the edema in that area, and as a unilateral lower extremity type of swelling or edema. And then another cause of unilateral lower extremity edema is some sort of lymphatic obstruction leading to lymphedema. So lymphatic obstruction or lymphedema. We had talked about the vascular causes, right? But now there's also the lymphatic system that can be obstructed or compressed, leading to more likely leading to lymphedema, causing the swelling. And then when you think about lymphedema, there's actually primary causes of lymphedema, and then there are secondary causes of lymphedema as well then. So some of the primary causes of lymphedema is basically when you're born with a hypoplastic lymphatic system or an aplastic type of lymphatic system. So the common one that you think about in pediatrics when you have congenital lymphedema would be Turner syndrome. When you're born, you have kind of puffy feet, puffy hands. That's actually lymphedema then. So that would be a congenital cause of primary lymphedema. Other causes of primary lymphedema, I'm just going to move these here, so let me do an arrow here just so that we have some space. So primary lymphedema, again, we mentioned Turner syndrome, but then there's also something called lymphedema precox. So lymphedema precox, P-R-A-E-C-O-S, so lymphedema precox, and then there's something called lymphedema tarda. So these are the most common causes of primary lymphedema in patients who are in the adolescent age, versus the Turner syndrome would present more at birth. But primary lymphedema, lymphedema precox and lymphedema tarda are the most common causes of primary lymphedema in adolescents and in young adults. And the difference here is the age. If it presents less than 35 years of age, then it's called lymphedema precox. And if it presents beyond 35 years of age, then it's called lymphedema tarda. And basically what happens is that you have a hypoplastic lymphatic system, and then ultimately as you grow older, the hypoplastic lymphatic system is not able to drain the lymph efficiently, and you start to get lymphedema. So that's primary lymphedema. Secondary lymphedema, the most common cause worldwide is filariasis. So our patient has a travel history to the Caribbean area, maybe that is going on. So filariasis is the most common cause of secondary lymphedema. So that's an infectious cause of secondary lymphedema. Other causes of secondary lymphedema could be just from chronic venous stasis. That can cause secondary lymphedema as well. We mentioned the infection and the filariasis. Then another common cause of secondary lymphedema is related to malignancies and radiation and surgery. So patients who have breast cancer have the tumor removed, have their lymph nodes in the axilla removed, so then they don't get good drainage of their lymphatics in that area. That can cause ipsilateral lymphedema as well. So, and then further radiation to the area can also cause lymphedema as well. So trauma and surgery and tumors and radiation and excision of the lymph nodes can all become common causes of secondary lymphedema. So those are some of the things you have to consider on a patient coming in with this type of picture of lower extremity swelling. So our patient had unilateral lower extremity swelling, so we were thinking more in this category, although just to think about patients coming in and have a broad differential diagnosis, when a patient comes in with lymphedema, if it's bilateral lower extremity swelling, not with lymphedema, but with swelling of their lower extremities, if they come in with bilateral lower extremity swelling, you think about renal causes, cardiac causes, liver, GI, and endocrine. And then when they come in with unilateral leg swelling, then you think about vascular causes, localized issues, and then lymphatic type of causes of the unilateral lower extremity edema. So now let's go back to our patient and see how the case unfolds in this patient then. So when our patient presented to the clinic with her findings, we started a little bit of a workup as an outpatient. She wasn't sick enough to be admitted, so we did some workup as an outpatient. And we got some basic labs, so we got a CBC and a complete metabolic panel, which were essentially normal. She was anemic, her kidney function was good, her liver enzymes were normal, her albumin was normal, protein was normal, so that helped us start to rule out some of the things we were thinking about on our differential. We also got thyroid panel, and that was normal. Her urinalysis was normal, didn't show any type of protein loss or anything like that. So all the labs were pretty reassuring. We got a chest X-ray on her just to look at her heart size to make sure she didn't have any signs of heart failure or pulmonary edema or anything like that. And her heart and her chest X-ray was totally normal. Her heart and lungs were totally normal. And then we sent her for a Doppler ultrasound of her lower extremity to look for any type of DVT, look for blood flow in the lower extremity, make sure there's no compression, external compression for some sort of tumor or anything like that. So she had a Doppler ultrasound of that right extremity, lower extremity, and that did not show any clots, it did not show any DVTs, it did not show any issues. There was normal venous blood flow and arterial blood flow. So essentially that was normal at that point. So then we just kind of followed her over the next several weeks to see how she was doing. We recommended that she try to elevate it at home and try to wear some compression stockings to help her with that, as she had some of this workup done over those few days. And when the workup came back normal and negative, we made a presumptive diagnosis of lymphedema, given all of her normal labs that suggested no clotting issue, no vascular issue, no tumor, and there's no localized findings or changes. And because it was unilateral, we didn't really think about this side of the differential diagnosis, and we made a presumptive diagnosis of lymphedema, most likely primary lymphedema, and since she was less than 35, of the lymphedema precox was our working diagnosis then. And based on exam, this was non-pitting edema. So that it made it more likely to be lymphedema versus if it was pitting edema, then you might think about other causes, cardiac causes, and protein loss, and other things. But because if it was non-pitting edema, we thought it was more consistent with lymph fluid that we were feeling, and then most likely she had lymphedema then. So again, given her age, the presumptive diagnosis was lymphedema precox, and that is the most common cause of primary lymphedema in adolescence. Lymphedema precox does affect women more than men, and it's 4 times more common in females than in men, and that's usually the most likely diagnosis for the primary lymphedema. And again, typically your lymphatic system is hypoplastic in that area, so you can look into the vessels, the lymph vessels, to see what's happening. And there's a couple different tests that you can do, radiographic type of test that you can do. One is an isotopic lymphoscintigraphy. So basically, you inject radioactive isotope into the lymph system, and then in nuclear medicine, then you watch it kind of light up, and you see what's happening with the lymphatic system and see if it's hypoplastic. Or you can do radio contrast lymphangiography. So again, injecting radio contrast material into the lymph system and kind of tracing it and watching the lymph vessels and see if they're hypoplastic. So our patient had the lymphoscintigraphy, and it did show hypoplastic lymphatic system in that right extremity, that right lower extremity. That helped confirm the diagnosis of lymphedema, and most likely primary lymphedema with the lymphedema precox, given that she was less than 35 years of age. And we didn't suspect any secondary causes of the lymphedema. So again, the treatment for lymphedema is many times just supportive. You elevate the extremity, having some exercise and trying to increase the muscle tone in that area can help drain the lymph tissue. And then you can use compression stockings and compression devices to help it as well. And then it's important to do a lot of good skin care, because bad lymphedema can cause breakdown of the skin in that area, and that can lead to skin infections and cellulitis, and lymphangitis and things, and also in severe cases, untreated cases, it can cause elephantitis as well. So there's some significant complications that occur if the skin in that area is not taken care of and overall is not addressed then. So we made that diagnosis in our patient of lymphedema precox, and helped her with some of the supportive care, and that seemed to make a difference and helped her with her with the leg swelling that she had, and it got better over several months then. So again, this is the differential diagnosis of a patient coming in with lower extremity edema. Our patient had unilateral right-sided lower extremity swelling. So we were thinking about these things on the differential, but if a patient comes in with bilateral edema and bilateral lower extremity swelling, then you have to broaden your differential and think about some of these other categories. So I did not go into a lot of details about a lot of these entities, but again, the idea of the CRASH case is to kind of think broadly, come up with a differential diagnosis on how to approach that type of patient, and then you can on your own you can go back and read about specific diagnoses that were brought up and how they might be causing edema and swelling in that type of a patient. But again, the goal of the CRASH case is to just kind of think through the case, come up with a broad differential diagnosis, and in our case it was a patient with lower extremity edema. So hopefully this CRASH case was helpful and beneficial, and we look forward to seeing you at the next CRASH case as well.